a great pleasure to be here in Almaty, and it's a great honor actually to talk for this meeting. And I would like to thank for the invitation, not to mention that it's always a pleasure to meet with Alua Obakirova because we have a long-lasting collaboration, not only a collaboration, but also a friendship. So I will talk about our experience about anterior segment disease in retinoblastoma. So first, as you know, there are different types of seeding in the anterior chamber. You can have class 1, 2, and 3 seeding. Actually, the seeding can be primary, so occurring present at diagnosis of the retinoblastoma, or can appear during the course of the conservative treatment. So it's a secondary seeding. Both of the seeding types are usually treated by enucleation. Now, you have a differential diagnosis. Here on the left, on your left, is a true seed of retinoblastoma, whereas on your right, it's Elschnig pearl in a patient with congenital cataract and aphakia. The seeding can be spontaneous, occur spontaneously, or can be iatrogenic, secondary to an intraocular surgery like vitrectomy or cataract surgery with a posterior rhexis. Now, I want to insist on the fact that when you have a seeding in the aqueous, it's resistant to intraarterial chemotherapy, and it's also resistant to intravitreal chemotherapy. So IAC for intraarterial, IVIC for intravitreal chemotherapy. So when you have tumors in the aqueous, it's resistant to all modalities. Also, very important feature of aqueous seeding, it's the only seeding type. Unlike the subretinal seeding or the vitreous seeding, it's the only seeding type that is associated with a metastatic risk, because you can have a growth in the angle of the anterior chamber, and then if the tumor grows, I don't know if I have a pointer, no. Anyway, if it grows through the trabeculum, it can invade the Schlemm's canal, and then you are in the same situation as a choroidal invasion. So now, with the modern imaging, with anterior OCT, we can assess if the Schlemm's canal is invaded or not in case of anterior segment disease. You have here the demonstration of a growth across the trabeculum on the right at 4 o'clock and an invasion of the Schlemm's canal. Now, the technique itself is illustrated here. I hope it's not working. Can you activate yeah. This is the technique of intracameral injection. So with a very thin needle of 34 gauge, with a long passage in clear cornea, we enter the antechamber. The goal is to create complete atalamia. So we empty completely both antechamber and posterior chamber. You see the cells coming from posterior chamber, and you empty, and then you replace the volume that you have retrieved. You replace it by the drug melphalan or topotecan, and you have to inject in the posterior chamber. So it's why you will see we perforate the roof of the iris and inject from the posterior chamber, and you see the cells coming from the posterior chamber. You see a lot of cells coming from the posterior chamber into the anterior chamber. Okay, now the good news, 5 years ago I was in Almaty for the 20th anniversary of the oncology department, and we presented the 5 years experience of this approach, and we had a 71% success rate. Now we just published our 10 years experience with an increased rate of salvage of 85%. The good news is also none of the cases treated had developed metastasis. None had a sight-threatening complication of the treatment. And we have a long follow-up, mean follow-up of 4 years. So it's a good follow-up. You see here the eye survival with after injection of topotecan or melphalan at this concentration of 20-30 microgram per ml. These are some emblematic cases with the pre and post treatment status. So we have excellent response with the intracameral chemotherapy for aqueous seeding, iris and endothelium, as well as epitrabecular implantation. We have also have excellent response when the seeding is invading the Hanover canal or the Petit's canal. But I have to say that if we have this type of implantation of the seeds between the ciliary processes, it's an interciliary process implantation, the intracameral chemotherapy is not enough to control the disease. You have to put a plaque, a radioactive plaque. Brachytherapy is required. Of course, if you have an invasion of the uvea, anterior uvea, either the iris or corpus ciliaris, of course, the intracameral chemotherapy is not enough to treat the disease. You have to also treat with a plaque the uveal involvements. So my conclusion, I think we have enough now follow-up to say that the intracameral chemotherapy, ICC, is safe because we don't have any case of metastasis, is efficient to control aqueous disease. There is no irreversible vision-threatening complications. And of course, additional treatment to intracameral is required if you have anterior uvea involvement or interciliary process seed implantation. Thank you.